Welcome. I am Mary Tierney, the Vice President of Editorial and the Chief Content Strategist for Cardiovascular Business, and I'm so glad you're joining us today. We are going to have a great conversation around a new heart failure program and continuum at Duke University Health System. So they have embraced and adopted the strategy to relieve heart failure symptoms for patients and are seeing really good success with the patient outcomes. So they also have some great advice to offer on program building and ways to optimize reimbursement when you're bringing in a new technology like Barostim. So I'd love to introduce the panel, and then they'll tell us a little bit about themselves, and then we can dig into the conversation. So I'm joined by Dr. Murat Fudim, who is the Medical Director of the Device Clinic and Director of Research at the Heart Center, and Dr. Joanna Kipnis, who is the Associate Chief Medical Officer within the Patient Revenue Management Organization, as well as the Medical Director of Utilization Management. And with CVRx, we have Bonnie Handke joining us too, who is the Senior Vice President of Patient Access, Reimbursement, and Healthcare Economics. So Dr. Fudim, can you just introduce yourself and tell us a little bit about you?
Yeah, so my name is Murat. I'm a heart failure cardiologist at Duke, trained in advanced heart failure, but play a lot of my time or work a lot of my time really in the pre-transplant, pre-LVAD space. That's where other device technologies and diagnostics are coming to play, and the world that is really preceding the transplant VAD world is the one of remote monitoring and device-based therapies, as the one we'll be talking about here next.
Great. And Dr. Kipnis?
Hey, my name's Joanna. I'm a hospitalist by training and still practice and see patients at Duke Hospital. I'm also very involved in our revenue cycle organization and utilization management with special expertise in regulatory payer behavior and authorization.
Okay. And Bonnie, quickly too?
Sure, Bonnie Handke with CVRx, and my responsibility here at CVRx is to ensure patient access to Barostim by removing barriers such as coverage, coding, and payment.
So let's jump in. Dr. Fudim, we know obviously that heart failure is a growing problem. Can you tell us a little bit, can you walk us through the pathophysiology of heart failure?
Yeah, so heart failure comes, in a lot of flavors. We refer to them as phenotypes. Maybe just, to take a step back, with about 7 million people in the United States that have the diagnosis of heart failure. It might be actually a much larger number. This is just a patient we have, a knowledge of. This number is unfortunately growing. We're going to have 9 million people just by the end of this, decade of 2030. We'll have 9 million. And it's about a 50-50 split between the two main phenotypes. And the phenotypes are divided by the amount of squeeze provided by the heart. If your heart is weakened with an ejection fraction of less than, let's say, 40 or 35%, we refer to these patients of heart failure with reduced ejection fraction. And then the rest above that we call heart failure with preserved ejection fraction. So now the heart failure with reduced ejection fraction, that's what we're going to focus on a little bit more today. They have a lot of drug-based therapies available to them that has been, a flourishing space, and also more device therapies available to them over the last decade that have been introduced, including Barostim and some other device-based technologies, and remote monitoring. So we can monitor these people, we can give them drugs, and we can escalate them also to device-based therapy. So that's what we do on a day-to-day basis. And if that is not sufficient and patients progress, now you need to go to specialized centers that then also offer you advanced heart failure therapies, and that is transplantation or LVAD. And God forbid, few patients unfortunately end up getting those type of therapies. That's less than 1% of patients actually end up getting these type of technologies. But you really want to keep the 99% of patients with heart failure with reduced ejection fraction away from the advanced heart failure therapies.
Can you just dig into exactly what Barostim is and what it does?
So barostimulation therapy is a device-based approach, which is actually not new. We have been thinking, or this field has been thinking about it since the 1950s and 60s, about stimulating the nerves of the carotid, around the carotid artery. This is a reflex that's called baroreflex. It's one of the key reflexes in the human body that regulates blood pressure and heart rate, but has a lot of other effects on the entire body, including the heart, where it regulates its stress tone, called sympathetic tone, or rest tone, called parasympathetic tone. Now, the baroreflex primarily regulates it rest and digest tone, the parasympathetic tone, regulating up, and in counterbalance, decrease the stress tone, the the fight or flight mode, so to say. And so the idea here is that if you dial up this reflex, which is otherwise suppressed in patients with heart failure, you are able to compensate for this reflex being downregulated, which has been downregulated probably for many years in most patients with heart failure. So this is just a compensatory mechanism you turn on now electrically. And what we see when you turn on that reflex in patients that, we have a reduction in stress tone. You can actually measure that in the blood or through the nervous system. We have, some positive effects on the kidneys, positive effects on the blood pressure in the heart. And that's a mechanism of action. That actually has been tested in randomized trials where we gave it to patients and we didn't give it to patients. And we looked whether we could make them feel better, keep them walk further, and whether we could reduce this biomarker NT-proBNP I was referring to earlier. And it actually improved all of those components individually, which led the government, the FDA, to actually approve this technology. So that has been approved since 2019 for clinical use in the United States based on a series of clinical trials.
And just for anyone who's not real familiar with the actual device, can you just describe the actual device?
It's a pacemaker that looks like this. We refer to it as an IPG. It's an implantable pulse generator. That's like a pacemaker defibrillator, just smaller. It goes into your left or right subclavicular region, so it needs a cut here, and it requires a cut in the neck where you actually deploy that lead, the flexible lead that stimulates the nerve. So there's two cuts, and you tunnel the lead under the skin, so there's no additional cut connecting that lead. So now two little cuts. The procedure itself is something like 40 minutes. You usually use general anesthesia for that. The procedure is actually very straightforward. The key part about this procedure, which makes it unique, is that it actually never enters the vascular stream. So it's important that pacemakers and defibrillators are actually inserted inside the heart, inside the vasculature, which increases the risk for potential infections down the line. This device is entirely outside of the vasculature, which decreases, by the way, the risk of complications during the implant itself, but also seems to minimize the risk of infections. The battery lasts around 5 to 8 years in best case scenario. It's always on. And once it's implanted, it requires 2 to 3 steps to titrate it up. So we're juicing this device up over the subsequent 1 to 2 months when the patient comes back into office.
So can you dig a little bit more into Barostim and kind of where that falls into the continuum?
Once identified, the first step, no questions asked, to start them on good medical therapy. We colloquially refer to that as guideline-directed medical therapy, or GDMT. Why? Because our guidelines tell us, that's our Bible, our commandment is to follow specific instructions, and there are 4 or 5 drugs we will be initiating on patients pretty automatically, pretty protocolized, and we give ourselves about 6 months time to get those meds on. And if there's no improvement in the squeeze of the heart beyond that 35 or 40 threshold, we tend to then consider escalating beyond drugs to now device-based therapy. So some device-based therapies are defibrillators. That is what's also recommended by the guidelines. The other device-based therapies, such as cardiac resynchronization therapy, CRT, mouthful there. There are only small pockets of patients that are eligible to this. Barostimulation therapy is one where you could consider escalating to as well if you remain symptomatic and the ejection fraction, the squeeze, remains below 35. So you have symptoms, your squeeze is still low despite good medical therapy. You have already considered the CRT device, that other device that is recommended highly by the guidelines. And now all of that has been done and considered. Then you can consider barostim stimulation therapy. There's one additional criterion that we evaluate patients for. We need to make sure that the heart is not too far along, not too sick, because too sick patients actually don't benefit from this device-based therapy. They need to maybe then go to transplant and VAD. One marker for that we'll look for is the NT-proBNP. It's a biomarker in the blood that swims in the blood to indicate the stretch of the heart. That just needs to be below 1600 ideally. That's it. Those are the 3 criteria: ejection fraction, symptoms, NT-proBNP less than 1600.
We know that there are a lot of heart failure patients out there, but who are the right patients for this procedure and device? And when really should people start thinking about using this device?
Well, patients should be starting to think about this. They, as patients, or we as providers, when we have a patient that has been following all our commandments, they're on all the medications they're supposed to be on, and yet even though they have been marinated in those drugs for 5-6 months, they remain symptomatic and the ejection fraction remains low. So they didn't recover the heart and they remain symptomatic. And symptoms can be, quite debilitating for heart failure. I mean, that's what heart failure is famous for. It makes people feel awful. It limits their ability to do independently functioning. They can't go to the mailbox. They can't go to the bank. They can't go shopping. They even sometimes can't even walk across the room at home to the restroom without getting short of breath. These are the typical symptoms patients experience. I'm not even talking about the swelling that many patients have or chest pain. You have that despite medical therapy, and 6 months or more passed since you started that medical therapy. You as a patient should ask the doctor whether there are other options, including this therapy. And as a doctor, you have to think, well, that hasn't gone as good as it should have gone. Are there additional options to consider? It's sort of like a second-line therapy beyond the guideline-directed medical therapy. That's how we consider that.
So Dr. Fadim, so is this procedure being done on an inpatient or an outpatient basis?
This therapy is offered for us so far. We have implanted everybody as outpatient. I have not looked at our data from a rehospitalization burden. We theoretically have that data nationwide. There is actually a nationwide presentation as a late breaker that was presented at THT, was a conference in Boston in, I think, March this year or February this year, where they presented nationwide all implanted devices that get tracked through databases. There was a reduction in hospitalization from pre to post in a single arm study, meaning everybody got the device and they looked in the 6 to 12 months pre-implantation, the post, and there was a dramatic reduction in hospitalization and rehospitalization afterwards. Now, I don't have that experience at Duke because we haven't looked at our data. I wouldn't be surprised that it would be not different from that. I mean, I don't think that we gravitate from that experience. I would say on an outpatient basis, in general, we just have happier patients because you can offer them something that I often did. And I think very important, something we haven't talked about, half of the patients we implant actually have self-identified and presented themselves to our clinic. Very, very important.
I guess one last question to you, and then I want to jump into Dr. Kipnis. Where are these patients coming from? I mean, within your organization or outside, or where are you?
Yeah, very good question. I think the patients that self-identify the 50%, about a half and half split of inside and outside of the system. So about a quarter of all patients are not completely new to our system. A quarter are within the system, but they were never in our heart failure group. And then half is just reshuffled within my partners and myself. People do travel for this and other services around heart failure because there's also not that many specialized heart failure centers out there.
So you've presented a great clinical value story. Dr. Kipnis, I'd love to get you into the conversation to offer perspective too on the kinds of challenges that Duke faces when bringing in new technologies like this. So what does this look like from a back office perspective?
Sure. So I think anybody listening to this knows that authorization just in our current landscape is a challenge. It becomes even more challenging, I think, for new technologies, medications, services. There's really two areas that need to be thought about before starting a program. One is what you need to do before the patient has the procedure to hopefully secure reimbursement, and then what you might have to do after the procedure to secure reimbursement. If anybody thinks they're going to start a program and implant new devices and not have denials, appeals, problems with authorizations, they would be incorrect. But I think it's very manageable. So there are really two scenarios that we see. One is, I should first say that Medicare, traditional Medicare, is a governmental payer that doesn't require prior authorization. Medicare sets guidelines for when they'll pay for something and when they won't. And from the very beginning, we've had no problems getting reimbursement from traditional Medicare. So your traditional Medicare patients, as long as you pick appropriate patients and have the appropriate documentation, that has gone very smoothly. For the commercial payers or the Medicare Advantage plans, you can expect that you are going to have to do some legwork to make sure this gets authorized. Either you are going to ask for prior authorization ahead of time and they are going to deny, calling it experimental, or because it's an outpatient procedure, they are going to say that we don't give prior authorization for an outpatient procedure, and then will deny it after the procedure. Either way, you have to have a system to appeal to the company and explain why this isn't experimental. The later somebody or a health system gets into putting these devices in, the easier I think this will be to manage. Payers learn by repetition. When they start paying these claims across the country and they start losing appeals, the bar to approve will come down significantly. The other thing that's important to understand is that when a new device, medication is new to market, it gets what's called a temporary code. And a lot of insurance companies' computers kick out temporary codes as experimental. So it does not surprise me at all that this gets denied as experimental. There may not even be a human reviewing the case. It's probably all computer generated.
What we should point out too is that what we're dealing with here is not just unique to this device, but this is just how a healthcare system works, right? I mean, so basically, whenever you're bringing in something new, you're going to have these problems.
This is anything new: medications, procedures, devices, implants, anything new that gets a temporary code, we see this problem with, and it's across the country. This is not unique to North Carolina.
And maybe this is also not unique to cardiology, but in cardiology, we have a particularly high cadence of new drugs over the last 10 years and devices. So sadly, we are painfully used to the idea of doing pre-authorization for anything new. Sadly, we're used to anything that's in the first few years of approval by the FDA, even though it's no longer experimental, it's approved by the government, that we'll have to fight and have a lot of rejection. So we have gotten a lot of rejections up front and sort of a slow trickle down to have more and more approvals as we go along. And together with the help, of course, of our office that Joanna leads, I mean, this is a lot of work.
The other couple things I want to add that I think are important is that what we've done is we've partnered with CVRX to have the company actually help us support us in the authorization process. While this is so new, almost every case, almost every non-Medicare case does require intervention at some point. And this also has a little bit of a longer timeline to approval than, say, our traditional requesting hip replacement surgery. So we have CVRX helping us with some of the prior authorization and also with some of the appeals for denials we get after the procedure is done. This has been really important because one, at Duke, our authorizations, we're working on thousands of authorizations for different things every day. And this is pretty niche. It's really important to getting this up and running that you're able to do cases to build your program. The second thing is that because CVRX is helping us and other health systems, they're learning pattern recognition as to which companies behave in which ways, which help us then, get good, robust data of how we're going to have to proceed and set patient expectations. It's important for a patient to know, we think we're going to get this approved for you, but it may take us 90 days. That's very important so they don't think this is going to happen next week. By and large, with the help of CVRX, we are getting appropriate reimbursement on all of our cases. It just isn't as easy as we would like if we design the system. I truly believe that we will see less and less denials moving forward as payers learn that we will dog these down to the end and they will ultimately lose if have to go in front of an administrative law judge, which is like a mediator who listens to both sides. Secondly, these temporary codes that get assigned to devices, medications, eventually get changed to permanent codes. And those permanent codes are much easier to work around because the payers don't have computer systems and AI that kicks them out. And thirdly, When something is FDA approved, Medicare will often make a coverage determination, and all you have to do is follow their coverage determination. Commercial payers and Medicare Advantage plans write payer policies, and they don't tend to write them very quickly for new technologies. But I think it's important to know that with our partnership with CVRX, we are getting our reimbursement appropriately.
And I'm going to bring Bonnie into the conversation soon, but I want to jump into this one too, because I know, the patient candidates also, you've had sign an assignment of representation in the office for approval. So can you go through that process? Because I think it's really interesting, because obviously the physicians need to get involved in that as well. So how has that facilitated the process?
For CVRX to help us with the prior auth and appeal work, they have to be able to appeal on behalf of the patient. They're not the contract is between the payer and the patient, and Duke always has an assignment of representation. It's part of our admission paperwork. I bet it is for most health systems. So when the patients talk to the physician that they need to, that they want to do this device, we've had the patient just at that time sign an assignment of representation form that says, CVRX can have your name and your date of birth and your insurance company and can help to do the approval. To my knowledge, no patients have been upset about that. They want this device. They want to get it approved. Most patients at this point know that insurance companies and prior authorization is a real headache, and they're happy to have that done. Normally, we do not make it a habit of having specific physicians' offices have to get forms like this signed. But for something, this is really just coming from one clinic. It's one device with one company. This felt like the best way. And once the kinks are worked out, we will likely bring the authorization process back into house and do it ourselves. But we are just not that nimble. We can't work as far out on authorization, and I don't think we would have been nearly as successful getting to 20 patients with a lot more in queue if we had been left to work the authorization and appeal kinks by ourselves.
All right, Bonnie, so you need to be a part of this conversation. I know you've got some great insight from other programs across the country that you're working with as well. So can you speak more specifically to the coding and reimbursement for Barostim and kind of where we are?
Certainly. And first of all, I want to say Dr. Kipnis brought some very valuable feedback and information that I think all should really pay attention to, because in order to set expectations, you need to be aware of all of the things that you're going to need to do. And like both Dr. Kipnis and Dr. Fadim said, when you bring a new technology to market, there are many things that you need to do in order to achieve payment ultimately and patient access. Across the United States right now, there are three things that need to happen. The first is coverage, which is, as we discussed before, prior authorization is required for those insurance companies that are not Medicare traditional. And with prior authorization, each plan administers it slightly different. So it's important that you know what those differences are. CVRX does have a team of individuals who can help facilities and physicians with their prior authorization. We can help with appeals and initial prior authorizations. It's important that you take these appeals and prior authorizations as far as you can go. There have been several studies out there that have demonstrated that most offices don't go beyond the initial denial. And when you do go beyond that initial denial, you have a very good chance of getting that ultimately approved. And yes, it does take longer. We are already starting to see some of the Medicare Advantage plans are approving much earlier. Historically, it would take 90 days. We are seeing some of them come in within 30 days, which means that that patient is able to receive the therapy much sooner. The other important factor is payment. And across the United States for Medicare, payment is established in both the outpatient and the inpatient facility. So patients are able to receive the care in the site of service that is most appropriate for their medical condition. Doctors can choose what is appropriate and schedule accordingly. Physician payment is currently what we call carrier priced. As Joanna mentioned, we do not yet have a Category 1 code set for Barostim. This will be implemented on January 1 of 2026, and at that time there will be relative value units established and predictable transparent payment amounts will be established in the Medicare physician fee schedule. That will also help us with some of these authorizations because we will no longer be under these experimental codes. So that will happen on or about January 1st of 2026. The other thing I just want to make sure all are aware of is the resources that CVRx has in terms of billing and coding guidelines, prior authorization materials, as I mentioned before, and appeal information, as I mentioned. The important thing is, as you are submitting your claims, you get your prior authorization and everything is going well. If you don't then submit the claim correctly, that's another opportunity for the insurance company to deny it. It's easy to use the wrong codes. It's easy to include the wrong documentation. So it's important that you are meticulous in terms of what you submit on your claim so that the claim goes in and is processed accordingly.
I want to, get Dr. Freeman back in the conversation because I really think it's important here from the physician and the more administrative reimbursement perspective. I'd love to get your advice and lessons learned in starting this program, and kind of what advice would you pass off to your colleagues in doing a similar venture?
Yeah, I think it's actually pretty straightforward. You need to have a champion. This is not a program that has to be, if it's getting pushed down from top to bottom, which I doubt it happens, it's not going to work. You need to have a dedicated person, ideally a heart failure cardiologist, but doesn't have to be it can be a regular cardiologist, so to say, and interested in the heart failure space, that they take it on to see those patients and become like a dispatcher or like an airport dispatcher. You go there, you go here. It's very important because there's coordinating with insurance and people like Joanna, coordinating with company, coordinating with patients, with referring providers, and providing this device clinic follow-up. I mean, you need to titrate the patients. Not a hard job at all, but you need to have those things in place. So it took us actually a while, easy 6 to 12 months, just sort of the planning phase. By the way, it sounds like a long time, but for an academic medical center, that's nothing. So we had our sweet 6 months easy of planning time to get ready for this program, and so then once we actually we didn't have to stop because we were overwhelmed or because we didn't have the right follow-up in place. Everything was smooth. We had bandwidth to do the procedures, all of those type of things. Oh, and on surgeons, that's the other thing you need to coordinate with. Make sure that you have war time. So champion, that's the one thing. If you have a champion, the rest is easy because now it's actually quite templated of what you need based on prior experience from other centers the company will share with you, or peers share with each other as well, because there's actually groups of peers that exchange on what is needed to build a program around this technology.
And Dr. Kim, from your perspective, what's the advice that you would pass on? What are the lessons learned that other people will find very valuable?
I think just having the expectation up front that there is going to be some extra authorization and denial work around this device. I do not expect it to last forever, but until it's, super well-known, super mainstream, there's a lot of policies around it. I think just if an organization goes in knowing there's going to just be a little bit more front end and back work and revenue cycle work, then I think that, everyone will be set up for success. It's false expectations that drive people crazy. The only other thing that I can think of that Bonnie alluded to, there's now a DRG assigned for this technology. The 20 patients Duke has done have all been outpatients, meaning people we identified in the clinic, posted them for a surgery, 2 months later, did the prior authorization work. We now have an opportunity to do it as part of an inpatient heart failure admission, or for the right patient, bring them into the hospital. That for us takes a little bit of operational work because we have to have the operating room time, the surgeon availability, stuff that's a little bit more nuanced to manage on short notice than it is on long notice. But I'm working with Murat and some of the other members of our team to figure out how to operationalize offering this as a device as part of an inpatient hospitalization for the right patients. And then that would roll up under the appropriate DRG, which is new.
Other facilities that are starting programs are at a definite advantage for the lessons that you have already learned and shared and things like that. So I guess we really need to thank you also for plowing the ground in that. So.
No problem. Yeah, and some of the payers I can tell just from our own patients are catching on. And the timeline appears to be getting better, and everybody listening to this will be in a different part of the country with different payers and different contracts. So it's hard to make huge generalizations, but they do learn by pattern recognition, roughly.
And I would add that we're tracking that as closely as we can, and we can also provide some insight to providers so they have an understanding going into it as well.
Thanks, Bonnie. And all right, we have moved into the live question and answer session. And Dr. Kipnis and Dr. Fudim and Bonnie are ready to take your questions. We already have a bunch of questions that have come in, and I really hope that you can keep them coming. And we have about 15 or 20 minutes or so that we're going to chat. So let's jump into our first question. And I'm hoping that, Murat, you can take this question. Is the device MRI conditional, and what are the restrictions?
So recently, the company received the ability to, it is approved to be used for head and neck scans and low extremity scans. So you wouldn't be able to do it for cardiothoracic scans, for example. So yeah, so we have, I think we had one case actually where we used it for like a brain scan.
Okay. And maybe you can continue on the next question too. Is Barostim like vagal stim, and how does it differ from that?
That's a good question. So, there are a number of nerves you could certainly stimulate for the purposes of neuromodulation, but the vagus nerve stimulation actually is not an approved technology for the purpose of cardiovascular disease. It's currently approved for the management of things like migraines, not for the purpose of heart failure. So that study got actually early terminated. So no, they work slightly different and not in a market space competing with each other.
All right, thanks for clarifying. That makes good sense. Joanna, you are next up, and everyone else, please feel free to chime in too. What are things you and your team consider when physicians approach you about bringing in a new device or therapy like this, and who are the people involved in that decision making?
That's complex. Whenever a physician at Duke wants to do something new, once it's gone through all of the sort of clinical approval processes through the hospital or the pharmacy, whether this is medication, procedure, device, depending on the company, we work with the company to get the right information. We work to make sure that we have all of our internal processes, just the nitty gritty stuff. It has to be loaded into the computer. We have to find out how we bill for it. Is there a T code? How do we, do the claim? We have to understand our payer policies, and then we, go live usually one at a time and figure out the kinks as we go, to be honest. There's a large number of people involved in that. So there's the clinical service line and their leadership, as well as our revenue cycle people on sort of all ends of the revenue cycle. So our prior auth teams, our denial management teams need to be aware, because new technologies often come with growing pains and denials, as well as our sort of people in our revenue integrity. And then depending on the cost of an item, I don't know that we have an exact threshold, but certainly when we start to get into things that are millions of dollars per pop, and I can think of 3 or 4 of those things that we do at Duke off the top of our head, that involves higher level sort of financial and clinician leadership.
Murat, back to you. Who places these devices, EP, interventional, vascular?
So these devices can be placed by many specialties. For us, in the most common version is usually vascular surgeons, followed by thoracic surgeons, And there is some few cases that even electrophysiologists can place this.
Okay. The next question, I guess, Marat, maybe you can start us out, but I think everybody, we'd love to get everyone's kind of feedback on this one because it's more of a general question. But what advice, and I know you've already offered a whole bunch of it during the webinar, but I guess we'll dig in a little bit deeper here. So what advice do you have for hospitals starting a program from the specific MD and administrative perspective?
Yeah, I think the point came down to, having a champion. I mean, it is in the beginning you need somebody to be the lightning rod that gathers a team around them, and that is a team that does the implant. That's a surgeon and his or her admin staff, because there is quite some planning involved. You need to schedule the preoperative ultrasound and get the OR lined up. Then somebody in cardiology needs to see the patient. It doesn't have to be a heart failure cardiologist. I would say that the champion is probably best suited to be in the cardiology space, a heart failure doc, ideally. And then, that's where Joanna and I come together. You need to make sure that that champion also makes sure that the billing side of that is all, the administration is all squared away. So that is a key part. If you have one person that is willing to take on some extra work, without doubt, that is not reimbursed work that you need to pull programs together. I mean, there are certain people that love to build programs and certain people don't. So that needs to be someone who likes to build programs, put in some extra time, some extra sweat equity.
Joanna, what would you add to that?
Yeah, I mean, I would say full disclosure, actually, I didn't get involved personally until we had already started doing some of those cases and were met with denials and prior auth problems of the kind we discussed during the presentation session. I think it's a good learning opportunity that there should be more revenue cycle people involved up front. New technologies hit the market at an ever-increasing rate, and most clinicians who are caring for patients don't understand the nuance of just because something is FDA approved does not mean payers are going to jump to cover it. So I think up front, trying to anticipate what the pain points will be, and then having a plan to execute on those is really important.
And then Joanna, maybe you can continue too. So you mentioned that you have CVRX handling your PAs. We have lots of staff who do that. Why is it useful to use CVRX for that?
Yeah, I think there's a couple things. One, you guys are really just concentrating on one, maybe two soon products. Our prior auth team is handling thousands of procedures and devices and medications. So there's just not the kind of expertise. I also think that you guys have pattern recognition from doing this for many health systems. We can only pattern recognize what's happening within our own walls. So you guys were quicker to understand, oh, this payer has this pattern of behavior. This payer has this pattern of behavior, to help cut down on some of the chaos and know where to focus your attention. And then lastly, there's just mutual interest here. It benefits you guys to have them approved. It benefits us to have them approved. You guys have a nimbleness and a lawyer and a team of people who can really see these through until such time as prior auth for this fades into the background as new things occupy payers' denial practices, and then we can probably absorb that. But I think the lead time that's needed, the appeal work up front, the appeal work on the back end lends itself really well to having a team that is just completely focused on this one thing.
All boats rise. So all programs are benefiting, right? From all the knowledge.
Yes,
Collective
for sure.
knowledge. Yeah.
Yeah.
And actually, Bonnie, it's your turn because there's a specific question with CVRX. So how large of a volume do we need for CVRX to be our advocate?
Yeah, great question. And we actually don't have a volume requirement. We will help you regardless of whether it's one or many. And as Joanna said, we are here for you. We do assign our staff by account, so you'll be working with the same people for the most part, who really will get to know your practice as well as what's going on across the country.
Great. Murat, I'm going to get you. I'm going to get you back in here, and I will warn that this is a longer question, so a couple different parts to it. So, a recent HFSA consensus statement states that the persistence of NYHA class 2 and above symptoms following 3 to 6 months after initiation of pharmacological GDMT and CRT where applicable should result in consideration of device-based therapies for heart failure. How do you assess that in your practice?
Yeah, so I think you need to set yourself just these type of term limits that when you start medical therapy, drug-based therapy, and 6 months into it, maybe even just 3 months into it, because that's when we assess candidacy for patients needing ICDs, so CRTDs. After 3 months, you're already eligible to assess that after initiation of this guideline-directed medical therapy or GDMT. So once you reach that 3-6 month mark and you saw an absence of improvement of the ejection fraction, the heart hasn't recovered, and you have a patient that had persistent symptoms. Class 2 symptoms mean symptoms. This patient is infinitely higher risk than somebody who is asymptomatic. Symptomatic heart failure is always bad. So once you get the idea that the patient is symptomatic and has not improved the ejection fraction, no longer than 6 months, you need to ask yourself as provider, what's my next play? Because accepting that this is your new normal is not okay. And so that's where, the guidelines are pushing now us to go really, really fast to titrate GDMT. And after 6 months, we need to ask ourselves, what's the next play? And that's usually consideration of device-based therapies, inclusion in clinical trials. That's where you own it to the patient and their families to offer them the next thing. And that's where, barrist simulation is one of the things that I always offer my patients when they meet those criteria. Ejection fraction less than 35, NT-proBNP less than 1600, and have persistent class 2 or class 3 symptoms.
So we're not seeing further decline. Makes total sense. And the good part is you actually answered all of those multi-part questions in your answer. So that's great. So terrific. Bonnie, you are next up. What are the most common reasons that you see claims denied?
So I would say that there's 2 common reasons. The first is if a prior authorization was not done and it's required. That is one of the reasons why we do offer the prior authorization services, because all plans aside from traditional Medicare should have that prior authorization performed. The second is typically simple billing errors. So the wrong code was used or something was omitted from the claim. We could say that they're simple things, but when you're new at doing this, they are very easy to make. And most of these things are able to be fixed on the backside, but obviously we'd like to have you get it right the first time so that you have success without having to go back in and fix it.
Okay. Joanna, I think this was discussed a little bit, but just obviously a little bit of confusion must arise here too. But what are the differences in reimbursement and navigating payment with procedures done on an inpatient outpatient basis? ASC is an option as well, correct?
At the beginning of doing this, we've only done them on an outpatient basis for patients who got, screened in clinic, consented, did the prior auth if needed, etc. As of this year, there is a DRG assigned to this device. And so we are working on operationalizing the ability to do this for inpatients who meet the clinical selection criteria. That takes more than just understanding how to bill. That takes making sure you have surgical availability and OR availability so you don't have long delays between identifying the patient and putting the device in. But we hope to start offering this to inpatients, and that would be handled under a DRG payment.
Great. Bonnie, there's another question as far as the reimbursement in these areas. Can you go through those again one more time?
The reimbursement, so certainly. There is payment established by Medicare in both the outpatient setting, the inpatient setting, as well as the ASC. On an outpatient setting, the average reimbursement is about $45,000. It maps to APC 1580. On the inpatient side, it maps to DRG 276, regardless of complications, comorbidities. All of the Barostim procedures will map to DRG 276. That on average is about $44,000. And in the ASC, The average payment is about $43,000. There is
Thanks
also
for,
payment, one more quick thing. There's payment
yeah.
established at most of the MACs for the T code, and that range is from around 5 to 600 up to 1,000, depending on the MAC jurisdiction that you happen to be in. And I can answer any of those questions offline if customers have a need to know.
Okay. Yeah, that's easy. Yeah, there. And I should mention too that specific questions, Bonnie and Joanna and Marat can also reach out to you guys as far as answering those things and stuff like that. So that's good. How are physicians screening for qualified patients? Are patients being identified by the PCP, general cardiology populations? What do you see in your practice?
The majority of referrals are coming from heart failure colleagues, local and regional, and then cardiology, sort of the second most referring group. Self-referring, there's a number of self-referrals coming to where patients, know about this product and just reach out through the company web portal. So that would be the third source of referrals. And what was the other question?
And then are patients being identified by the PCPs and general cardiology, or where are they coming from, I guess?
So the funny is actually this trigger thing. The trigger here is that most people actually don't think about it. You say screening. I think very few people go through a database and say, hey, how many patients do you actually qualify for this? We do it a little bit like a lemonade stand in clinical practice. Well, patient comes through, they complain about shortness of breath, and they want to have something else. In many cases, actually, the patient's triggering the provider to think about something next. I think in very few instances, the clinicians are aware of what's available, including in their own institution, and then offer that up front. And I think to some degree, this webinar is intended to raise the awareness for that. I can tell even in my practice, not every physician in my group is aware of this being an availability. So we have to do grand rounds, recurrent exposure to these things. So everybody's aware. So I think that I don't know that many programs are doing active screening. That would be the right thing to do. Right now, it's truly just the patient in front of you. Do you recognize the need to treat symptoms, improve functional capacity, and have enough time to bring it up? That's the other thing. I mean, people are pressured in that 10 minutes there with the patient to discuss all the other things that are part of the basic routine, and then think of this novel device-based therapies, which is why novel device-based therapies and drug-based therapies always struggle a little bit to, get a foothold, just because there's other 100 things we need to discuss with a patient in 10 minutes.
Okay. Okay, makes sense. Makes good sense. All right, I hope you can continue as well. What are the things you focus on during your shared decision-making conversations with patients? What do you tell your patients is the biggest benefit or impact that they may see from Barostim?
This is a very good question. It's a little bit sort of what's the spiel, right? And the spiel, I think, is for me is that here's what we tried that the guidelines tell me I had to tell you about. And this is, drug 1, 2, 3, 4. There's 4 to 5 drugs we consider guideline-directed medical therapy. We assess your ejection fraction. Now the ICD and CRTD were considered. And I tell patients that these were class 1 indications. This is what I absolutely had to do. Now we will focus on your symptoms and your functional capacity. If you feel that they're impaired, you would like to have a better quality of life, and you would like to have less shortness of breath and improve functional capacity, then the next best step would be to consider this therapy, which is approved on the U.S. market. And I list them what those options are. And then, by the way, in the same vein, I'll also tell them about what might be beyond the reach of the FDA, meaning now we have, so to say, clinical trials, because we do a lot of clinical trials in our institution. So that's my spiel. We have done what we need to. Here's the next step. If it's for you, I'll tell you more. If it's not for you, then we'll continue as is, which people often sort of put a pause button on it and come back and realize, well, there were options you told me about. So I'm never disappointed when I present people with this menu of options that they say, oh, I have to do it right now. They'll come back to it eventually.
Dr. Murat, I'm sorry, Murat, I wish you'd continue with this next question. What other benefits have you seen or do you anticipate in patients beyond the heart failure symptom improvement?
That is a good question. So I think it's important to recognize that when the study was done, they measured the Minnesota Living with Heart Failure questionnaire. This is a quality of life questionnaire similar to the Kansas City questionnaire, the KCCQ. And there's a number of domains, something like 6, 7 domains that are getting investigated as part of these questionnaires. And these domains are not restricted to symptoms in heart failure. They are really around activities of daily living. They are around psychological well-being as well. And Minnesota, living with heart failure. Actually, I actually don't remember the questionnaires. That I don't know if they ask about sexual function, but the KCQ actually does, because the quality of life of a human being affects so many different domains. So in general, yes, when patients report improvement in my clinical practice and in clinical trials, it is not restricted to actually shortness of breath alone, believe it or not. That is one of the questions we assess, but it's not the entirety of the question. So I think it's a global quality of life that tends to improve, and might be on the on the surface not related to heart failure, but at the end of the day, it does all come down, of course, to the pump function of the heart.
Okay, Joanna, I'm going to take one. This is going to be our last question because I want to be mindful of everyone's time as well. So Joanna, would you be able to share some of the false expectations that your team encountered?
Well, sure. I mean, I can say this because I'm a physician. Physicians always think that everything's going to get approved super easily because it's the right thing to do for patients. Unfortunately, that's just not the healthcare system that we work in. Marat is not a Pollyanna, so he's been very easy to work with. But in general, physicians just don't understand denials, lack of auth, lack of payment. I think that it's just, I said this in the presentation, I think it's just really important to set expectations that new technologies and new device, you'll get everything paid. It just takes a little bit more scrappiness. And you have to understand if there's a payer in your health system space that is just not going to have a policy on this or is just not going to pay it. And especially when something has a T code, I think you really have to have your spidey sense up, because the way the payer's system works, T codes will automatically trigger experimental denials, even if it's not experimental anymore. Clinical standards always outpace computer systems and billing and coding. And then the last thing I would say is as someone who works heavily in the revenue cycle, I always subscribe to the philosophy that you do the right clinical thing for the patient, and then the money will follow appropriately. So I think there was an earlier question that only got half answered about whether it's better to do the device in the hospital or to discharge them and have it done as an outpatient. I mean, largely in general, and it depends on your payer, you will recoup more money if you, let's say if they have traditional Medicare, if you get a DRG payment for the inpatient stay for heart failure, and then 2 months later you do the device as an outpatient. But the decision should be made based on what's clinically best for the patient. If it's clinically best for them to have it done as an inpatient, well, now there's a DRG for that. If it's best from their social determinants of health to do it while they're in the hospital, now there's a way to get that done and get reimbursed from our care. So thinking about how to maximize revenue is important, but I think right now, as this progresses, there's a whole suite of ways to make sure we get reimbursed for the work we're doing. And if we just provide this device for the right patients at the right time, no matter what the setting is, it will all work out.
Patient care number one. That's great. Thank you so much for your insight. We're going to stop here. So I do want to thank you so much, Dr. Kipnis and Dr. Fadim and Bonnie, for your insight. This has been a great conversation, and I want to thank everyone for really sharing those great questions too. I think it really made our discussion very lively and meaty. So, and like we've said, we've plowed the ground here to make it a lot easier for programs going forward as well. I think that's super important. And if you'd like to listen to this webinar again, or share it with a colleague, we will be sharing a link to do so. And you're welcome to share it far and wide with colleagues in your whole team. Cardiovascular Business will be emailing that directly to you. We'll also share in that email some additional resources and assets for program building and nurturing and things like that. So I want to say thank you so much for being a part of this, and have a great rest of your day.